It's time for Mature Muscle with Lee and Phil.
Hi everyone, welcome to Mature Muscle Podcast. This is episode 5. We've got a cool one today. We're going to be speaking to a couple of guys. One's a doctor and one's a mountaineer. A bit of a strange combo, I know, but the reason we're putting them together is and having a chat is because Nick Hollis is a mountaineer and athlete, is a friend of mine. He got struck down, probably the least expected person really to be hit by long COVID. And he was really not in a good way, but I'm sure he'll go into that in a bit. So I'm not going to go into that too much depth now. And Dr. Deepak Ravindran is a bit of a pain expert. He's chronic pain expert, and he's also written a book called The Pain-Free Mindset, which is it's available on Amazon. We're going to talk about that a bit as well. But it's quite handy because he's a expert in pain, as I've said, but he's also knows quite a lot about long COVID. So I'm going to hopefully get a few little pearls of wisdom and about a bit of an explanation of what's happening, really, why some people have had it, some haven't, etc. So that's basically a little bit of a intro and a fill-in. So we've got quite a bit of info, hopefully, regarding chronic pain as well. So that's the main reason for getting the doctor on, because we all know that you get injured. You get, I know you've got a bit of an injury, haven't you, mate? Your shoulder. I've had a bit of a lower back issue. So with a bit of help, hopefully we can try and get to the nuts and bolts of why we get chronic pain and if there's anything we can do to mitigate it. So there we go. So we'll get them on board in a second and see what we can find out. Okay, everyone. So we've got Nick Hollis and we've got Dr. Deepak Ravindran. So we're going to call him Deepak because he's more than happy with that. So let's have a little bit of a background from Nick first, if you don't mind. Just give us a quick whistle-top tour of what you do, what you're doing right now, and what you've done in the past.
Yeah, thanks, Lee, and it's an absolute pleasure to be here speaking to you today. So, for myself, I have a background from the corporate world, and I spent much of my life working as a corporate employee. But 10 years ago, my life completely changed course, and I reinvented myself as an expedition leader and adventurer. And the last 10 years have just been this most amazing journey. I've spent a lot of time out in the mountains on big expeditions. And during that time, I've climbed a number of mountains you probably know, including the Seven Summits. So that's the highest mountain on each of the 7 continents, and that includes Mount Everest. And prior to the pandemic, I was bang in the middle of a Guinness World Record attempt to be the first person to climb the 7 summits, ski to the North and South Pole, full distance solo, and row the Atlantic. But right now, all my plans have been a little bit skybosh, shall we say. I've caught COVID, about 13 months ago. I was out in Arizona at the time, training for the Marathon des Sables. And I thought it was just going to be a 2-week illness that would wash over. And little did I know that I was going to be one of the unlucky ones, one of the COVID long haulers. And the last 13 months of my life, how shall I say, have very much not gone to plan. In fact, it's been the most extraordinarily difficult journey. That said, I've not given up at any point. I'm back training and I'm getting myself fit for my next adventure, which is the Atlantic Row. That's 3,000 miles across the Atlantic. And that is scheduled to take place in December this year.
Excellent. Thank you very much, mate.
Awesome.
Just makes us all feel very lazy, but yeah. And would you mind giving us a little bit of your background as well, please, Deepak?
Well, thank you. Thank you so much, Lee, for having me today on your podcast there. Good to be meeting and coming face-to-face with Nick as well. So my name is Dr. Deepak Ravindran. I'm a consultant and the lead for the pain medicine services at the Royal Berkshire Hospital. I've been in the NHS as a consultant since 2010. Prior to that, training around in Oxford and London for my fellowships there. And since 2020, end of December 2020, I'm also the clinical lead for the Berkshire long COVID service that we've started here. This is one of the 60 long COVID clinics that the NHS and the central government wanted to have in place to support people with long COVID. My other interest is essentially pain medicine. Very passionate about that to the extent that I've now released a book which has been published by Vermilion, imprint of Penguin, and it just came out last month called The Pain-Free Mindset.
Excellent.
Awesome.
That's we're going to talk about that a little bit later on as well, because that's something that I think will interest a lot of our listeners. But one thing I wanted to go back to Nick with first is, obviously, a lot of people out there don't necessarily know much about long COVID, and could you tell us what symptoms you noticed and how long they lasted, and what makes long COVID different? So if you start with that, Nick, and then we can get maybe a little bit of medical side of it from Deepak.
Yeah, of course. So if I give you a little chronological journey, I had COVID for 2 weeks. I felt unwell, flu-like symptoms, but I would describe it as flu with a difference. I felt weird, strange, an incredible fatigue, an incredible malaise. I had a little bit of a headache, but nothing too major. But the most notable thing was this brain fog. It was this inability to do anything cognitively, even writing a text message, writing an email. I'd look at a screen and the words would just look like gobbledygook to me. But after 2 weeks, I started to improve. I had a mild cough and my symptoms started to improve. And I recall probably 3 weeks post-COVID, trying to go for a walk, leaving my house. And it was the most extraordinary thing. Literally within 5 minutes of leaving my house, I felt very dizzy. I passed out. I was lying down on the pavement. And I ended up calling an ambulance.
I remember you telling me about that, calling an ambulance for yourself. It's quite a shocking thing to hear from you as an endurance athlete.
Yeah, I mean, I just could not get myself up and I could not get myself back home. But I wasn't hospitalized. They ran some tests. They said I was checking out okay. I wasn't hospitalized. After that, I started to improve. So I contracted COVID in March. April was a write-off. But by during May and June, my symptoms were improving and I was able to go back to training. I was never 100%. And the other thing with this journey with long COVID, it's not linear. You'd have good days and you'd have bad days. So you've got this expectation with an illness that you're progressively going to get better. It's just not the case with this long COVID. But then I got to the end of June and I had an almighty crash. It was quite extraordinary. Over the space of about 3 days, I went from being an active human being to being largely bedbound. And it was just unbelievable. I was literally spending my day either in bed or on the sofa. I was counting my steps. I was averaging 500 steps a day. I couldn't work. It was absolutely impossible. I needed to close down my business. And life was just completely put on hold. It was extraordinary. And this went on June, July, August. And it was getting to the point where it was really dark. It was really desperate. I just did not know what to do to help myself. I contacted my GP. I had a number of the standard medical tests, checks, X-ray, full blood work, everything checked out as normal. And I'm also very lucky because I've got an expedition doctor. I've got doctors on speed dial due to what I do, but they couldn't help me either. They were researching, they were looking at the situation, but nobody had a solution. Nobody had an answer to this.
When did you start coming out of that then? At what stage did you start feeling a little bit more like yourself?
It was interesting. It was in September. So after spending 3 months, and it got to the point where I just decided to put everything into recovery. And I went a little bit left field. So I started acupuncture. I started Wim Hof practice. I started seeing a therapist, something I've never done historically. I started using yoga. I've always been someone that does meditation, but I got really big into the world of mindfulness, meditation, just trying to calm down the body. Because for me, as a non-medical person, it just felt like my fight, flight, or freeze response was permanently engaged.
Right. So you get adrenal fatigue and that kind of thing. And
yeah, it felt as though I was awash with adrenaline, and it felt like my sympathetic nervous system was switched on and my parasympathetic nervous system had gone AWOL. That's the best way I could describe it.
Okay.
But after the acupuncture and a number of measures, things started to calm down. Things started to improve. It was very gradual. It was definitely not linear. And I've had a gradual return to health ever since. We had a blip over Christmas where I came down with shingles. You would not expect me to have someone of my fitness and age to have shingles, But again, that was something else that occurred on that journey.
Okay, brilliant. Could you shed a bit of light medically on that? So obviously that someone like Nick, one of the big questions I think a lot of people will have is how can someone like Nick who's super fit have a condition like long COVID where you'd expect maybe someone of weaker and maybe less fit to have, and I know it hits anyone, it's indiscriminate. So can you give us a little bit of background why it is such a strange one?
In fact, I probably would want to say that, Nick, you are the absolute poster child for what we've been trying to, and we've been telling patients on how you can recover using a comprehensive kind of mind-body therapy assortment of techniques right now for there. But you're spot on, and really thank you for setting it up really nicely in terms of what to do for the condition. So primarily, what is long COVID and why did somebody like Nick get it? There are a couple of ways to think about this, Lee. One is with long COVID, or essentially what we're seeing in COVID, is that when you have a virus, absolutely new virus coming through, at the end of it, how your immune system is primed to recognize an external threat is going to be the ultimate determinant of what happens to the COVID infection. And for those people who have had really severe COVID infection, who have needed hospitalization, who have needed to be on an ICU, therein is the balance where the immune system actually goes completely rogue. It causes an entire amount of collateral damage, which damages the organs, and that's when people have a severe COVID. So the viral infection as such is only a part of the problem. It's the exuberant immune response that often has been the problem which brings people into hospitals or in ICUs and very, very unwell and almost dying.
So almost like an autoimmune situation.
It is. And in long COVID, we've actually now recognized, and we've been having this clinic now for the last 4 months. We went live from December 1st. We've been receiving referrals from all around Berkshire there. We've, I think, triaged about 300 plus patients, seen about 150 plus patients. And the major group is around the 20 to 60. The people have been fit and healthy like Nick, obviously not endurance athletes and high level performers, but definitely fit and healthy triathletes, runners, otherwise, completely normal, no other comorbid conditions, both male and female. And what happens in them, what we assume right now, is that they have a response, an immune response to the virus, which allows them in getting rid of the virus in about a week or 10 days time. But then for some reason, just as Nick pointed out, the immune system just stays on hyperactive. And over time, we've realized now that long COVID is not, or long haulers, as the Americans have called it, is not just one common simple condition with the defined features or symptoms that people have. It's actually a multi-system problem. And it may actually be a common term for 4 different conditions. You have a kind of long COVID-like symptom people, those who have come out of ICU, where deconditioning and being on a machine and having organ problems is an issue. You then have a group of people who have had single organ problems, their heart or their lungs have really brain or something has been affected during the acute COVID infection, and that's grumbling on. And the biggest group is this group of people like Nick, who are otherwise fit and healthy, who have fluctuating symptoms that go up and down, who have majorly affecting their heart. So they have palpitations and chest pain, who have lung problems, so shortness of breath and breathing difficulties, or sort of air hunger, as people call it there. And then you have those where a brain are affected, so cognitive dysfunction, not thinking clearly, not concentrating effectively, the overall brain fog, tummy upset, so GI upset, loss of taste, loss of smell, and then severe fatigue. I mean, when I looked at the first 100 patients that have come through the service, 98% had chronic fatigue, severe debilitating fatigue that can, again, seem to have, exactly as Nick said, days which seem to be quite good, and then suddenly you have a crash that lasts for about a few days. And it is completely upended how we have talked about rehab and recovery in these conditions. Why do we think it's happening? Right now, we think that one reason could be that the immune system stays constantly active. The second reason we're thinking is that sometimes some viral fragments of the virus itself may still hang about in the tummy, in the GI tract, or actually in sort of the olfactory bulb, sort of the
Oh, right.
smelling apparatus, the neurons in the brain. And every time the immune system catches scent of that viral fragment, it launches an attack there. And so people who are prone to these kind of good recoveries and then have a relapse or a crash, we think that maybe there's a bit of viral fragment. The third kind is this molecular mimicry. Does the virus fragment start to resemble a normal cell in the human body? And so then the immune system thinks, oh my God, there it is. I need to go after it again.
So it's
And
attracting
those
it.
are the people we start seeing a little bit of acute breathlessness or sudden loss of taste or smell or sudden tummy upset problems or chest pain or palpitations. All of these seem to be occurring. And a common theme we are finding in all of them is the autonomic nervous system. So where Nick pointed out, the sympathetic nervous system set out on a high, we find that the autonomic nervous system, which is essentially the sympathetic and the vagal tone, gets disrupted and dysregulated. So the autonomic dysfunction is what causes the shortness of breath, the palpitations, the chest pain, the air hunger, and sometimes can contribute to the fatigue and brain fog-like symptoms.
Wow, it sounds a horrendous situation, to be honest. I mean, I had no idea it could be. It's just a systemic thing.
It is almost the nervous and the immune system having a big dance together and then just going completely rogue.
Playing off each other almost.
And
so
Lee,
what's the long-term prognosis for someone like Nick then, who's been through this kind of long-term debilitating sickness? And we'll come back to you in a second, Nick, on that.
Well, one of the studies that came out a few months ago, which was very interesting for me because in terms of high performance athletes or people who are functioning much higher than normal when they get this illness, there is this thought process that actually in people who are already endurance athletes or at a high level of fitness, you have a sympathetic nervous system, which is already, and their immune system, which is already on a little bit of a high alert because it needs to kick into protection and healing much faster because such people are prone to small injuries or small, physical issues at some point much earlier than your average Joe. So is it the question that in those people where the immune system is already on a high, a viral infection then dips it completely and sends it even higher? And so are such people prone to long COVID or a post-viral syndrome that might last longer? So that might be a reason for some of these symptoms happening with Nick and what he said. But that gives us rise to what the prognosis, right now we are seeing patients. So I think I'm seeing patients who probably caught COVID in December 2019. I've met a couple of triathletes who've come to the clinic there and heard about them there. It is something that, as Nick has predicted, it seems to be going these up and down routines, but getting that combination, what we have not yet done studies on is what about if we can get people a combination of therapies to calm the immune system and the nervous system like Nick has taken on board? Is that going to lead to a sustained remission of the entire system and calm it down and help in complete prognosis? But otherwise, at this time, we are seeing about 30 to 50% of patients recovering around the 10 to 12 month mark. But then for the remaining, we're still having these kind of ups and downs, relapses and remissions. And we are learning from the time there that the pacing that we all talk about actually needs to be modified, and the rehab pattern and the regime needs to be modified even more slowly for people having this combination of fatigue and recovery delay.
Right. Okay. Well, that's great. So what you're doing, Nick, sounds like you've really kind of hit the nail on the head there. You've attacking it from two different fronts, kind of. So just go through again what it is you've been doing. You said you've been doing a bit more yoga, some meditation, and just fill us in again on what you found has worked for you.
Yeah. So and there's another piece to the jigsaw as well. So in the early stages, I became very, very sensitive to what I describe as allergens. So, for example, any pollen would trigger me, any animals. And I would feel as I was going into a state of mild anaphylaxis. It was actually quite frightening, to the point where I was going to request an EpiPen. Right. Now, for me, the game changer was quite interesting on that. And it was an antihistamine, but it wasn't an H1 antihistamine. It was an H2. It was famotidine. Yeah. And I spent a lot of time doing research, and I recognized actually the H2 receptors, if you can block them, that actually has an impact on your respiratory system. It's not just the gut, but it has actually quite a broad impact on the body functions. Right. And I could notice, and I was monitoring my peak flow the whole time, that if I was to use this H2 blocker, my peak flow would increase during this period. So that was one piece of the jigsaw puzzle that was really useful. Another thing that I did was fasting. Now, fasting again, and also spent some time following a ketogenic diet. I didn't believe in either before, but having tried them, they were definitely a part of that recovery journey, that process for me. But something else I've had a challenge with as I've moved through this journey is POTS, Postural Orthostatic Tachycardia syndrome. So, for example, if I lie down, I'll have a resting heart rate now of about 60 beats per minute. Pre-COVID, it was about 45 beats per minute. If I stand up, it will go up to 95 beats per minute. If I eat a heavy meal where the blood flow goes to the gut, it will, again, it's very, very elevated. Right. So from my own research, I've been doing a lot of self-rehabilitation, increasing hydration, increasing blood volume through electrolytes, and also exercise. But I'm doing that on a rowing machine, which suits me pretty well, given I'm rowing the Atlantic. And I've been walking this tightrope because the exercise improves the POTS symptoms. But as Deepak was saying, you're walking this tightrope because if you overdo it, then you're suffering with this thing that's described as malaise. Yeah. But just following this journey, I've taken myself from being bedbound to now I'm exercising typically 2 hours a day of training. The brain fog is not really a big issue for me, and the fatigue is no longer a really big issue for me. So the residual symptom, the thing I'm now most concerned about, is this postural tachycardia. So any information or ideas to address that, Deepak, would be very welcome.
I think, Nick, brilliant. Once again, you've highlighted all the things I tend to talk about in sort of calming the nervous and immune system down. So the anti-inflammatory diet that you've then, more importantly, the timing, intermittent fasting, a 16-to-8 regime, and you take it to that extent, you're going to slip into ketosis or ketogenic diet. And then the H2 blockers, is there something around mast cell activation, which is quite a big thing, as you would have read about, and I'm interested in it there. I think the evidence is happening now. There are some data and studies coming out from the US there. Luckily, the drugs are reasonably commonplace in the UK. So I'm starting to now recommend a few to the GPs to say, let's give a 4-week trial of these drugs to the patients if they've been struggling with these kind of symptoms. So spot on, really. I think everything that I've been researching and studying and thinking about, it's fantastic to see someone who's implemented and found it beneficial. So that's really useful to know. Excellent. With regards to your one residual symptom there, I probably would reckon, given where you are and what you want to be doing, I think if your doctors haven't already done it or suggested, there was a recent study. So just to put it in perspective, Lee and Phil and Nick there, the Organization for National Statistics came out just a week or 10 days ago saying that finally, right now, the number of long COVID patients or possible long COVID patients in the UK is 1.1 million.
Wow.
That is the number that they're looking at. And there is, therefore, a lot of research that's going into looking at this. And another study that came out from Oxford, where they did this extensive MRI scanning of all the organs, suggested that there is a high percentage of mild impairment of some of the heart or lungs or kidney at that time. What it means for clinical practice, I don't think it's still clear whether somebody should get that scanning or anything done. But coming to your point, Nick, I'd probably say if it is that tachycardia that's there, if there is an element of, the autonomic dysfunction aspect, you are sorting it by looking at all the POTS measures that you're doing. The option would be to say, is there a role to look at whether there's still any possible heart changes that are slightly keeping you below capacity and contributing to it. And the other option would be to look at a technique like heart rate variability and biofeedback of that technique. So if you can incorporate that element to look at palpitations there. And the third option would be discussing whether with your cardiologist, whether it is a point which would need maybe a little bit of medication to prevent those ups and downs from coming along. I don't know what your thoughts about any medications for a brief period of time are, but these would be the options that mainstream medicine is looking at right now for residual tachycardia symptoms.
Have you used heart rate variability, Nick?
Yeah, so I've used heart rate variability. I've had a 48-hour Holter, and I'm checked in for another. I've got another 48-hour ECG at the end of this month, and I'm booked in for an echo in August. So I've got that piece covered. What I haven't explored as yet is the medications, and I would be really interested, Deepak, to know what you've got in mind. My reservation has always been, for me doing what I do, I need to get insurance, and this is, you know, in 7-8 months time, I'm going to be 50, 60 days out across the Atlantic Ocean rowing, and I'm determined to go. So that's always the concern that I've got, is will I be able to get past a medical, be given that medical fit pass to actually go? But no, I would be very, very interested in looking at medicinal options as well.
Maybe we can get you.
You know, if it was a normal average Joe who doesn't have anything of that endurance level planned, I would have said that this is something that can be gradually retrained back. And listening, you know, I think there are few big experts on POTS in other conditions who've been looking after them. One such name, I think, is a cardiologist called Nick Gall, who works in King's, would be a good source to explore and visit to see what their experience is. But from taking on a lot of the reading and the research that's done to apply to my patients, I do feel that in your situation, we've reached the point wherein you've explored and put into place all the other non-pharmacological, non-drug measures, which would be my first preference as well. Once you've done that, you're looking for that small margins of performance, that small incremental gains. And the question is whether a 3 to 4 week trial of something like this at this time, combined with everything you're doing, can just turn the corner and take you beyond that first point. That's where I'll be looking at there. And so that might mean you get the benefit, but you don't actually run any, you know, afoul of any regulations or sign-offs.
Excellent. That's great. I mean, I'd love to talk more about that, but we're slightly restricted on time. So I want to bring you in through now to a little bit more about chronic pain, because we've got some listeners I think would love to hear a bit more about your chronic pain, but also a bit about your book as well, because there's obviously with weight training and with exercise, we find that there's several areas, kind of lower back, shoulder, as poor Phil can justify, you know, and your knees, which seem to suffer a little bit more than anything else. So, I mean, obviously there are points where there's a lot of stress through them. So that's the reason. But I mean, if we were to talk about chronic pain, and someone out there suffering from chronic pain, is there anything that you could say just now, just to give us a little bit of insight? Is there anything we can do to address that without obviously medication, dosing up on medication, which I also want to come back to as well?
I mean, huge amounts, Lee. Thank you for the question there. So in my book, it's called The Pain-Free Mindset. And I want to make actually clear that the acute pain and chronic pain, the only similarity between them is the word pain in them. There's a big, massive difference between acute pain, wherein you have a physical injury due to overtraining, due to maybe sudden exposure to increased loads or change in loads without appropriate supports or, you know, preparation in place. That is a different construct, because you do have a tendon change, you do have a muscle change, you do have muscle fiber injury. Now, each time an acute injury like this happens, you have a release of certain chemicals. Now, we always talked about, and when we were taught in medical school, which is not a very long time ago, more than 20 years, probably 2001, 2005, even now, the understanding was that these chemicals would come, these are the pain, and these pain signals will travel in pain pathways, which made us think that there are these clear roads of pain pathways which you could block with an injection or a steroid or a nerve block, or you can do a surgery. What I would like to bring to your listeners' attention is that actually these signals are very generic. When you have an injury, the signals that get released are absolutely the same kind of signals. Chemicals are the same. They travel in nerves that are very similar to any other nerves that carry any other sensation. When they reach the spinal cord and then they travel to the brain, it is the brain that actually then processes that signal and decides, well, what is happening? Where am I? What am I doing when this signal arrived here? What did I do the last time such a signal happened? How did I respond to that? And all of this is an algorithm that it predicts and decides whether the response needs to be one of protection, or is that something a threat, or is it not something relevant? And that decides whether the system will respond with what we call as pain rather than the release of chemicals, which is what I would call nociception. So that's the word I would like to say, is that acute pain is where 90% of the time is just nociception and 10% of the time is the experience per se. But in chronic pain, it changes completely. When you get to chronic pain, you may not notice much of a change if somebody did an MRI or something of your knee or tendon. People tend to call these names called tendinopathy or tendinitis or bursitis that keeps coming again and again.
Yeah.
What the MRI scans show is that they show some changes which look like there's inflammation, but they don't talk about the intensity of pain. That's because the amount of chemicals, the nociception that gets released in chronic pain is often very little or a small amount. Majority is actually the processing that happens within the spinal cord and the brain, which has got so used to saying, you know what, this is the moment that I did, this is what I did the next time, let's tighten everything up again, let's make everything splintered so that we can control and protect this person from whatever they're going to do next. So our understanding and the mindset shift that we have to have is, in acute pain, you can use anti-inflammatories, you can possibly get really good benefit from an injection or a surgery when there is a lot of nociception. But in chronic pain, drugs really are less than 30% effective, which is why you might have heard in the media and seen in the papers about these guidelines that have come out from the organizations. And you find that even surgeries for chronic pain don't work that well. They only make or risk making the problem worse, because as Nick said in his original thing, the fight, flight, or freeze response, if the threat system is already on a high, you go and do a surgery in someone who's got chronic pain. If you don't have a good enough nociception there, you're only risking making the system even more frightened. And so the level of pain goes even higher after surgery.
Right. Okay. So it's not always a fix. So in that situation, what's the best way to attack this chronic pain? Would it be through maybe just trying to calm the muscles down around that pain, that site? So, you know, where you're getting muscle spasm, whether the impulse from the brain is to protect the area, like you said, with some spasm. So often the spasm can be more painful than the pain itself, if you know what I mean.
Absolutely. And that's what we find there, that often it's trying to deconstruct that and actually reassure the patient or reassure your client, reassure your listener there that when you get a spasm like that, don't worry about the fact that your arthritis is flaring up. You do have anyone after the age of 20, when they did, you know, in the book there, I talk about the fact that they have done MRI scans on people who have absolutely no pain. They've done MRI scans of their knees, of their hips, of their back, of the neck, of their shoulders, of the elbows. And they have all found changes of meniscal tears and degradation and labral tears and injuries or things that would otherwise have been called as osteoarthritis or bone on bone. But these are people who have no pain at all. So actually the pain and intensity of pain has no correlation with what's seen on a scan. So when somebody has an injury or a niggling thing or gets a muscle spasm, the suggestion should be about, if there is no acute reason for injury, you know, if they've not had a fall, but they've tried to do something and it's gone into spasm, is of trying to say, well, what are the breathing techniques you can do to start relaxing the muscle there? Does heat or cold help? Can that be done? Can gentle stretches or rehab, those kind of measures be put in place? Do we use a TENS machine or maybe some acupuncture needles that might just allow some endorphins locally to be released, and that can relax the muscle out there?
It's a massage, maybe deep tissue massage and trigger point massage, that kind of thing.
Absolutely. So those kind of trigger point releases, myofascial release can be explored. Those are all the non-drug options. And I'm a big believer, or at least I think, like the way Nick was talking about, there is a huge role for looking at nutrition, the kind of stress management and anti-inflammatory styles, because what we do and look after a microbiome, you go on a high carbohydrate, high inflammatory, high processed food load, and then you suddenly try a few rehab or sudden take on exercises, and you have a little bit of extra visceral fat or that you're carrying, which are releasing chemicals of their own, that can provoke inflammation and cause a pain response, which is what we call these days as nociplastic pain. So where you have inflammatory chemicals being secreted or released into the body from some other sources other than the injury, they can still go to the area or the nerves where the sensitivity is there, and it can recreate the entire experience. But when you do a scan or when you do any kind of thing, there's nothing at all. And the patient would have pain one day, the next day it would be fine. Then they try something else, there'd be soreness on that day, then the next day they'd be fine. This would all be signs that actually you're having a sensitization in the nervous system rather than an acute injury.
That's what my shoulder's like.
Go on, sorry, mate.
That's what my shoulder has been like. I just had an MRI scan. I was lifting about 10 months ago and it just went ping. Got a bit of a rotator cuff. The scan showed the tendon and a little bit of wear and tear on the AC joint. Some days no pain at all. Some days there is. And I think it's related to, I also have ulcerative colitis. So I tend to have days where I flare up, my skin can be dry, my scalp can be dry. And I'm wondering if that pain is actually coming from somewhere else. And we've been locked down, my body fat's slightly higher. I haven't done as much cardio. My diet's been a bit looser than normal. So I'm wondering what's going to happen now. I've gone back to dieting, cardio, and the body fat's coming back down. I'm interested just to see if that will reduce the pain in that shoulder, as well as I'm doing some ART. My friend does ART and I'm stretching and doing some rehab. So that you've just described very similar to what I've had, where some days it can be pain-free. Some days it's really sore for no reason whatsoever.
Yeah.
And ART is autogenic reflex therapy?
Active release techniques. The American
active release techniques. Okay, fine.
Yeah.
Okay.
Yeah.
There's so many three-letter acronyms across this country.
Yeah. Yeah.
Well, that's really interesting because you mentioned earlier, Nick, about the ketogenic diet. Because I've been listening to several podcasts, for years about how ketogenic diets and especially low inflammatory diets, I should say. So things that is keeping away from the refined carbohydrates and all the links to leaky gut and all this kind of thing. So it's interesting to think that you could actually tackle a lot of pain just by maybe correcting your diet. So rather than dosing yourself with all the drugs, it seems to be a little bit more. It could potentially be a little bit more beneficial to actually look at your diet and allow your gut to heal a little bit better first.
This was something I did when I first got diagnosed with the colitis. I actually haven't been taking medication for about 5 years, and I followed like a very low sugar diet for a while, and I did some other bits, and I started making my own probiotics and using glutamine and trying to fix. And I did a lot of research on leaky gut, and touch wood, 5 years later, I don't take any medication. I have the odd bad day, but that was really helpful for me. And I'm wondering, that's where it comes back. I wonder if more people did that, they might experience less pain.
Yeah, exactly.
Hugely. I would definitely go there and actually give you a little bit of sciencey stuff there, and I'll try to keep it as less ungeeky as possible.
Yeah, please do.
And what we've realized, and actually the data from the research is showing out, is when this nervous system signal of what we call pain or any kind of injury and threat signal, a danger signal arrives in the spinal cord, we were taught in our medical school that, okay, the signal comes, the signal jumps across in the spinal cord from one nerve ending to the other nerve ending and then travels to the brain. We now realize there's actually a nice threesome out there. So right alongside the junction box there, you have a policeman from the immune system called the microglia, which sits there. Now, the glia is actually present throughout the spinal cord and in the brain. And we used to think of it, and when I was in medical school, I was taught that the microglia did nothing. It was just like a buffer. It was like your scavenger and your cleaning person out there. What we now realize, actually, as one of the writers had talked, it's the angel and the assassin. And in my book, I kind of talk about it like the Dr. Jekyll and the Mr. Hyde. When the microglia, when your body is in a low stress state and has got a good amount of support and buffer systems, whether that's good food, good social connections, good sleep, good stress management techniques, the microglia function as Dr. Jekyll. They nourish the nerves around them. They support the nervous system. They buffer the spinal cord, and they act in the intestinal nervous system, which is your biggest center for the immune system, is in your intestine. They do that. But when the stress starts to increase, and this can be a physical stress of injury or acute injury or anything that you're doing, or it can be emotional stress, whichever of that is going to activate the microglia and turn them into a Mr. Hyde. When they go into Mr. Hyde mode, they just are getting scatterbrained. They go about killing the same junctions that they've been nourishing. They can cause a lot of collateral damage in the brain and spinal cord. And a lot of cases, even within long COVID, I suspect, but also with CFS or ME and other conditions of neural changes, we think now that a lot of these Alzheimer's or early onset dementia or some of these other conditions where people are eating prolonged in Western Americanized diets, that prolonged inflammation is microglial activation and constant Mr. Hyde-like presence in these junctions, which are contributing to a variety of brain fog-like symptoms or pain symptoms or immune problems, skin rashes, urticaria, pollen, allergies, autoimmune conditions. It is a huge interest right now. And that's why ketogenic diets shift Mr. Hyde back to Dr. Jekyll. And the intermittent fasting going up to 24 hours shifts the change from Mr. Hyde to Dr. Jekyll. Use of certain drugs, sometimes cannabis at certain levels, some of the other medications that have been looked at, shifts Mr. Hyde to Dr. Jekyll. And that's what is the next focus for the next 10, 20 years. What do you think? Yoga, meditation, all of them change Mr. Hyde to Dr. Jekyll.
That's fascinating.
Amazing.
It's really fascinating because I've known about the benefits of ketogenic diets and fasting on the brain, on the cognitive and the brain fog side for many years, but I hadn't put that together with the pain. So that's an interesting twist for me. I mean, that's something I'm definitely going to take away from this. That's really fascinating. While we're talking about painkillers and anti-inflammatories, I mean, just quickly, because there'll be people out there who I know will take them far too often, and we're just looking at what are the long-term side effects of using them too much. I mean, can you just quickly just go through those for us?
By anti-inflammatories, I'm going to assume you mean things like diclofenac, ibuprofen, naproxen.
Exactly.
And the understanding right now is that beyond the age of 70, I tend not to prescribe them at all. I tend to stay away from them. If I have to give it, I tell them it should be for the lowest dose, for the shortest possible time. And if they're going to take it more than 3 days in a row, they need to take some tummy protection in place. It is an issue if you're on blood thinners. It is an issue if you've got kidney problems. It is an issue if you're prone to acidity and already got stomach issues. So as a group of drugs, they are fine if you've got, as I said, acute nociception related pain. They are okay to try for a few days, but with these caveats and these age groups in place. Otherwise, I think they work only 20-30% of the time, and we should be quite cautious of them. I do realize, of course, that a lot of people, your listeners might say, well, it works for me whenever I take it. And honestly, my father takes it once in a week, suddenly he gets it, he's back in India, he'll pop a couple of diclofenac and he'll say, yeah, I'm feeling happy, I don't want to stop taking it. So I know that if people have been used to taking it and are getting the benefit, I'm not going to tell them you should stop it, and I don't want to frighten them. But I think we are just being more aware and more cautious of who to leave it on long term.
Yeah, that's great advice. So in terms of the buffering for the stomach, what would be something that you would advise people to take for that?
If they can do over-the-counter Gaviscon and ranitidine,
Oh,
that's
right.
well and good. But if you
stop
want
the
to go
acid.
next step place is going to be one of these omeprazole, the proton pump inhibitors, the PPIs is what we'd be suggesting and asking the GPs to give a trial.
Excellent. Okay, that's really good. We're coming up close to time now, guys. I don't want to drag you too much longer on, but there's one other thing I'd just like to ask you while I've got you on, especially, and I'm going to put the details of your book in the show notes for everyone who's interested as well. For the link will be in the show notes for that. Just one thing is people's perception of pain. The RPE, if you like, of pain is why is it so different in some people? So some people can have such a high tolerance of pain, and others can have such a low tolerance of pain. Is there a mechanism behind that that's you can explain?
Good question, Lee. I wish I could give you a straight answer there. It is more complicated and nuanced than that. Okay. What we've understood, I think the science says, and although popular science would say that people have certain thresholds or they have a tolerance, within research, we haven't been able to establish that there is such a thing as a bar for pain tolerance that people can above or below.
Right.
What we understand is that, and that's where I said the nervous, and this is something as a learning for me as well in the last 7 years. And that's where I started to tell you about the immune system. We studied in medical school right up to 2008 or 9. We were told that the brain and the spinal cord has no immune system presence at all.
Right.
So that's the teaching in medical school that happened as late as this time. So It means that, but now we know that's a totally flawed concept. And similarly, pain is now a construct of the nervous and the immune systems together joining up to decide when there is threat to the existence of the organism. As long as it perceives a threat, it will activate protection mechanisms like pain and a variety of other responses that are mediated through fight, flight, freeze, or flop. And it's going to be able to get those responses acted out very quickly, consciously, and unconsciously in many people. So once you take that into account, the adult who stands in front of you who has got one injury and you have another person with the same injury, but then one person is in a lot of pain and the other person is not in any pain, our way of looking at it, and certainly my view of looking at it is, well, what are the factors that have combined the nervous and immune system in one person to tolerate the same injury for longer, while in the other person to express threat and protection at a much higher level. Right. And I do find that how their nervous and immune systems have developed from childhood to adulthood to what insults have been put upon it as they grow older, all of that goes into the mix. So it's almost like you got the eggs, you got the butter, you got the batter. Looking at the pancake, you can't say how much of the stuff is from the egg, from the batter, you can't separate it out there. And so I've just got this, I think one of physiotherapists on Twitter called David Poulter got this analogy of how can you actually tease it apart and say what came from where. And I'd like to probably say that within pain itself, the pain tolerance that someone tells you for the same injury is very much a function of their experience that has molded their nervous and immune system together.
Right. Brilliant. Well, that's a fascinating answer. Thank you very much for that. And thank you both. Cheers, Nick. And thank you, Deepak. Just before you go, Nick, would you like to tell people about your current challenge and how they can help if they so wish?
Thanks, Lee. I'd be delighted. Yeah, so the challenge is called 721 Challenge. 7 summits, 2 poles and 1 ocean. And it would be incredible if the audience could follow me on my journey. And they can do that using Facebook, which is simply 721 Challenge, Instagram, 721 Challenge, Or if you use LinkedIn, I'm Nick Hollis 721, because your support when I'm out doing these crazy things genuinely means the world to me. And the challenge itself is being done to firstly raise awareness for climate change, something as an expedition leader I see a lot of firsthand, but also to raise money for the international conservation charity World Land Trust, of which Sir David Attenborough is a patron. And the funding is going to be used to create a 4,000 hectare nature reserve in Guatemala.
Yeah, amazing.
Awesome.
That's fantastic. Thanks, Nick. And Doc, would you like to give us the name of your book again? Because I'm sure there'd be people out there who'll be fascinated with this. So feel free.
No, well, thank you, Lee, for having me on. And Nick, the very best of luck. And I'll definitely be following you. And that's fantastic work that you're doing, both in terms of the climate change and the challenge itself. I hope all the symptoms of long COVID just disappear very fast and in time for your journey there. For all the listeners there, my book is called The Pain-Free Mindset. It is available in all high street stores. I believe it should definitely available online and on Amazon there. And for anything else around the book and further talks and webinars around there, please follow me on Instagram, Dr. Deepak Ravindran, and on Twitter, which is @DeepakRavindra5. A little bit of a mouthful, but I'll leave it for Lee to put in the show notes.
Yeah, I'll put that in the show notes. Thank you very much, guys. That's been a really fascinating interview. I really appreciate it. Thank you very much.
Thank you.
You're welcome.
Thank
Thank
you
you this evening. Bye.
Bye.